A quick review of how we screen and treat for anemia in pregnancy and Ungava. So in the first trimester, for all women, we'll draw an FSC and a ferritin. An FSC is a complete blood count, and it looks at the hemoglobin levels in the woman, so how much iron is working for her, distributing oxygen around her body. Also, what are the size and shape of her red blood cells. And the ferritin is the stores, like how much iron does she have stored in her body that she's going to use to go on to increase her blood supply throughout the pregnancy and to grow her baby. If the ferritin is normal, above 30, we don't need to do anything. So we go on in terms of routine care. But specifically for at-risk women, we're also going to add a profile of the ferritin, so the transport proteins and the percent saturation of iron, as well as the B12 levels. So we're going to look at a more complete look at anemia in pregnancy or what else she has going on for her. As well, we're getting ready if we need to prescribe Venofer IV, then we have that baseline blood work already done. It takes a while to come back. For any woman who the ferritin comes back between 11 and 30, we call her iron deficient. And so she's going to benefit from iron supplementation at this stage of the pregnancy so she doesn't dip into iron deficiency anemia, which is ferritin below 10. With these women, we're concerned because iron deficiency anemia is associated with preterm birth, low birth weight, APGARs less than 7 at 5 minutes, as well as poor mental psychomotor development in the child. And for the woman, at the time of birth, if she were to lose a lot of blood, she's less likely to cope well in the immediate postpartum period. So even though we're going to look at the FSC in these cases and get a hemoglobin level, the hemoglobin isn't a very good screening tool for iron deficiency and iron deficiency anemia. So the hemoglobin, we're only going to look at in comparison to the ferritin. So if her hemoglobin is high and her ferritin is low, like 150 hemoglobin, ferritin 10, that's unusual. If her hemoglobin is low and her ferritin is high, that's also a bit unusual. And both of those cases warrant a medical consult. But really, just look at the ferritin. We want to correct her iron stores so that she has enough iron to go on to increase her blood supply and grow her baby. So what we're going to prescribe in the case of iron deficiency and iron deficiency anemia is oral iron. So these aren't oral iron salts, ferrous sulfate. They're cheap, they're easily available. You just take them once a day or take them once every other day. That's been shown to be just as effective. And 1 or 2 tablets a day or every other day. Advisors not to take it with calcium, tea, milk, or coffee, but she can take it with orange juice, or you can also prescribe 500 milligrams of vitamin C to take at the same time. She can take it at night before bed so that any sort of tummy upset doesn't, or gastric or belly upset, she can just sleep through it. And she may also need a laxative because iron is constipating. At this time, she can stop taking the Materna. The Materna, after 12 weeks, we've used it for the folic acid, but the iron available in the Materna really isn't available to her because it's in the presence of calcium. So it's just kind of a waste. Then we're going to retest in 3 to 4 weeks, and we expect her iron and ferritin to be coming up. One thing to note is, if possible, when you do a retest of a ferritin, try not to have her take the iron supplement that day because it's going to give a false high level. If there's improvement, you continue with the prescription. If there's no improvement, then we're dealing with, we just want to rule out. So provided she's taking these as directed, what we want to do is discuss with the doctor because maybe she has something else going on like poor absorption or she has some sort of gastric bleeding. So we just want to verify that we haven't missed something. Then in the second trimester, we're going to retest everyone for their FSC and ferritin. And if it's above 30, great, we just continue on in normal care. If her ferritin's getting low or even lower, we're preparing her for more for iron supplements, but we also want to rule out anything weird if we haven't done so in the last 3 months. We can provide iron supplements, but also really consider Venofer IV in the second trimester. So Venofer IV is just as effective as oral, but some people can't tolerate the oral, or some people's lives are too hectic for them to be taking a pill every day. The Venofer can give sort of a concentrated dose over a period of time, and we should see results in 3 weeks. You don't want to have to be providing Venofer for a woman just prior to her delivery, because she's not really going to get a chance to use that iron in the form of hemoglobin in her red blood cells that could help her if she were to lose any blood. So think really strongly about using Venofer in the second trimester. It gives her a chance to give it to her baby, so her baby's not born with low iron stores. If her baby's born preterm, it sets the baby up for the best case scenario in terms of iron stores, and it gives her a chance to convert that iron into hemoglobin and put it in her red blood cells and shuttle oxygen around her body for her and her baby. In the third trimester, we're just going to do a quick snapshot of hemoglobin. So ferritin takes a while to come back, but sometimes you can get one in before you do the Venofer. Basically, if you think you're heading for Venofer, do a profile of her iron and do a B12 so that we have that information within 3 months of prescribing the Venofer. If her hemoglobin's over 100, we just do routine care. But if her hemoglobin's under 100, we're getting ready for Venofer. All women with a hemoglobin under 100 in the third trimester should be offered Venofer. As well, we do something called a PPH protocol, or postpartum hemorrhage protocol. That's when the woman goes into labor. We draw her group, screen, cross-match, and match for 2 units of blood. We do an IV lock, and at the time of birth, just prior to the delivery of the placenta, we do active management of third stage with 5 international units IV push through her lock. If it's in the middle of the night and you've done your group screen cross-match, you can use your judgment whether you call the lab in to prepare the blood, or you just have it on reserve. You just have it in their fridge and it's ready to go if you're going to need a transfusion. In the case of the women who you've been following through a pregnancy, again, do an FSC and ferritin. And if their hemoglobin's above 100, the ferritin's above 10, great. You can just continue with the supplement she's already on. If the hemoglobin is under 100 or the ferritin's under 10, recommend Venofer. Again, trying to get the Venofer to her more than 3 weeks before you think she's going to give birth. Venofer can be given every few days, and so if you need to give 2 to 3 doses, you can schedule her for 1 dose, and then 3 days later a second dose, and 3 days later a third dose. Again, also a postpartum hemorrhage protocol where you're doing a group screen cross match for 2 units of blood. You're putting in an IV lock in labor, and when she gives birth, before the placenta comes, you're using active management of third stage with 5 international units IV push through her lock. In the case for women who you've been following through their pregnancy and really anemia has been an issue, in the postpartum period, refer her for H. pylori testing. And so we're not able to do this in pregnancy, but for women who have a bacterial infection of their gut that's caused gastric ulcers and therefore bleeding from their gut, they're losing blood. This could be a reason why they struggle with anemia despite us doing all our best to give iron supplements and improve diet. So this is something to do in the postpartum period, is arrange for H. pylori testing so that she doesn't have this problem in the next pregnancy. In the postpartum period, if she's had a normal birth, we don't do any extra blood work. But if she's at risk, she's had a postpartum hemorrhage of over 500 mils, she's had uncorrected prenatal anemia, or she has signs and symptoms of anemia now after the birth with breathlessness, fatigue, not really keen to lift her head off the pillow, then within 48 hours do an FSC. You'll have the results by the end of the day, and a hemoglobin above 100 is routine care. But if you're looking at like 90 to 100, under 90, but she's hemodynamically stable, she's asymptomatic or mildly symptomatic, we can prescribe 1 or 2 or 3 tablets a day, once a day, or every other day. And then we recheck her FSC and ferritin in 3 weeks to evaluate how the treatment's working. If she's under 80 or under 70, consider Venofer. We consider transfusion under 70, but research has shown that in trauma cases, Venofer is as effective as transfusion and safer. So consider Venofer in the woman who this could be a good option. We'd avoid the complications of transfusion as well as her developing antibodies, which could be a complication in the next pregnancy. So this is a quick review. Call the maternity if you're at the nursing station if you have any questions. But what we would like to see is women showing up to give birth with a hemoglobin above 100.